Thank you very much. So we're just going to give you our approach to managing SAM and how we do it at Mount Sinai, and hopefully provide you with some data as well as to our outcomes with that. So the plan today is just to discuss what is SAM, what's the incidence of SAM, when we do have SAM in the operating room, how are we going to manage it, and are there any new predictors for SAM? So we just, Professor Dion just described this to us. There's two different types of SAM. One is what I call primary SAM, and this nice paper by Sheridan and colleagues, they talk about because of the hypertrophic ventricle, the laminar flow in the ventricle is disrupted, leading to a pushing mechanism. In secondary SAM, which is secondary to valve repair, it's more of a Venturi phenomenon where the leaflet is actually pulled into the outflow tract, leading to SAM. When we look at the incidence of SAM, here's 3 papers, including ours, ranging from 5 to about 10%. And, we were just discussing here about using rings versus bands. That we know that the Mayo Group is very commonly using bands, but despite that, they still have an incidence of 8.4%. So I don't know whether it's an issue of whether using a complete annuloplasty ring versus a band, but I do think the size of the ring, as Professor Dion was mentioning, is crucial. But some people say, don't worry about SAM. It always gets better with medical therapy. Should we worry about it? Well, I would disagree. This is a paper published by Carpentier's group where they had a 48-year-old patient who 8 years later developed symptomatic severe SAM requiring reoperation. In the paper by the Alfieri group and this Mayo group, in the Alfieri group, they had 6 patients that required reoperation for SAM, 3 of them early and 2 of them delayed, and the Mayo group clearly showed that not all patients with SAM resolve. In this paper that we published last year, we provided an algorithm of how we manage SAM both intraoperatively and postoperatively, and I'll just go through that with you. This is the intraoperative algorithm for managing SAM. The first thing is you have to start off with a technically appropriate repair, which we've all discussed, with a posterior leaflet height less than 15 millimeters and an appropriately true-sized ring. If you come off bypass, you have no SAM, you go ahead and proceed to close. But if you do get SAM, then we do the medical therapy interventions that we talked about, avoiding the inotropes, getting the mean pressure up, increasing the preload, and avoiding tachycardia. Now, when we're talking about getting the mean pressure up, we don't believe you should artificially elevate it, to pressures over 100, what the patient wouldn't be living with on a daily basis. So we don't partially cross-clamp the aorta. We just bring the pressure up with some pressors and see what happens to the SAM. If the SAM resolves, you go ahead and close, get an echo in 2 to 3 days, and no SAM, no further management required. But what happens if you do the medical interventions and you get SAM? So then we divide it into the degree. So if you have minimal MR or a gradient less than 50, we go ahead and close, repeat an echo in 2 to 3 days, and assess for SAM. Usually, so far in the series that we published here, we didn't have any incidence of recurrent SAM, and no further management was required. But if the gradient is greater than 50 or we have more than minimal MR, then the consideration should be made to resuming bypass, and we're very liberal about that. Obviously, you take into context the patient's comorbidities and how long your first cross-clamp was, but in most cases, with just one single cross-clamp and one dose of plege, you're able to re-repair the valve. And oftentimes what we do in this case is we'll just displace that posterior leaflet using a shortened neocordi and do not have to change the ring size. Most recently, we've had one case where we actually had to upsize the ring, but for the most part, we were just able to displace that posterior leaflet with one dose of plege. We then go ahead, close, get an echo on postoperative day number 2 or 3. If there's no SAM, we're done. But what happens if you do have SAM post-op? Now we're 3-4 days out, the patient's on the floor, and they've got SAM. Well, you're not in the operating room anymore, so the story changes a little bit. So this leads us to our postoperative management algorithm for SAM. So again, it depends on the degree. If you have minimal MR, asymptomatic patient, and a low gradient, we institute the beta blocker therapy, repeat their echo in 6 weeks' time. And we had some examples of this just for the sake of time. We didn't go through. I'm not going to include all the echoes, but using this therapy, again, we've been able to resolve all cases of SAM. But if you have more than minimal MR, your post-op day 4, the gradient's greater than 50, again, we're trying medical therapy, increasing beta blocker therapy, avoiding diuretics if we've had the patient on Lasix, allowing them to be hypertensive, and assessing the gradient. If the gradient's low, again, discharge, repeat echo. So the bottom line is after the operation but before discharge, if you have SAM, medical management is our first key. If it doesn't get better with that and the gradient's still greater than 50, you have hemodynamic instability, or if the patient's symptomatic, then you have to consider early reoperation. In our series, we haven't had to reoperate for patients, but We have had a case series that we're about to put out with 8 patients who've had reoperation at our center, who've been operating on other centers that we've reoperated on for SAM from 1 year out to 11 years. And so it does occur, and patients do require reoperations. When we looked at this series of patients, our incidence of reoperation for SAM during the same sitting, so we did the operation, we came off bypass, we had some SAM, we had to go back on bypass to repair, the incidence was 0.6%. But when we looked at the series of these 6 patients that we reoperated on at the same sitting, we found that some of them had FEDs, some of them were formed through, some of them were Barlows, some had a ring size of 26, some had a ring size of 40. So that made us wonder, do we really know the predictors of SAM? So we went back and did a literature review, and a lot of the papers are from the late 90s, early 2000s. So we thought we'd have a fresh look at SAM. So what we did was we knew about the classic predictors which Professor Dion mentioned, which was an anterior posterior leaflet height or a ratio between them. We talked about the aortomitral angle, the coaptation septal distance, which really looks at where that posterior closure line is. The more anterior that closure line is, the shorter the coaptation septal distance. And we know about the undersized ring. But we decided to look at 375 intra-op echoes, pre-bypass echoes, and we looked at 11 parameters, things that we postulated would be risk for SAM. We looked at the ejection fraction. We looked at the left ventricular end systolic and diastolic dimensions. We looked at the septal diameter at the mid-ventricular level and the base. We looked at the posterior leaflet height, the anterior leaflet height, and the other common things, the aortomitral angle. And then we added a few other things. Left atrial diameter, was the mitral annulus diameter important, and the coaptation septal distance. And we tried to give cutoff points so that if we're in the operating room, we know what numbers to think about when we're thinking about a quote-unquote small ventricle or a quote-unquote thick septum. So these are the repair techniques that were employed, and we found that whether you did a sliding plasty or not, or a commissuroplasty or posterior leaflet resection, it didn't predict SAM. When we looked at the cardiac chamber size, we found that systolic and systolic dimension and diastolic dimension significantly predicted the risk of SAM. The ejection fraction in this series didn't, but you can see that there wasn't very significant differences in the ejection fraction. Most of our patients have an ejection fraction close to 60%, so it would be very hard to show a difference even with 375 patients. When we looked at the septal diameter at the base, it significantly predicted SAM as well as at the mid-ventricular level. Then we looked at the measurements of the mitral valve. So we did this, looked at the anterior leaflet, that was almost significant. The posterior leaflet height, as well as the coaptation septum distance, both predicted SAM. The mitral annular diameter did not, and neither did the annuloplasty ring size. But again, you can look at our ring sizes, they're almost identical in both groups. So we focus a lot of time on true sizing the ring. And then we looked at the aortomitral angle, and that was significant for predicting SAM. You can see those patients who didn't have SAM at an angle close to 130 and those that did under 120. Now, although we didn't show ejection fraction to be significant, I did want to point out this paper by Manabi and colleagues that was published at the end of last year where they were able to show that a hyperdynamic ventricle with ejection fraction greater than 75% increased the risk of SAM by 3.7-fold. So bottom line is, what were our predictors for SAM? An end diastolic diameter less than 45 millimeters increased the risk almost 4-fold. A septal diameter greater than 15 millimeters increased the risk 3.6-fold. The short coaptation septal distance, again, that really is a surrogate for where that coaptation line is. The more anterior displaced it is, the shorter that coaptation septal distance, the more likely you are to get SAM. Increase the risk 5-fold. A posterior leaflet length, which we all know about, greater than 15 millimeters, and then the aortomitral angle, which Carpante and colleagues have shown in the past. So in conclusion, the occurrence of SAM is about 5 to 9% after mitral valve reconstruction. SAM can occur with any degenerative pathology and after any repair technique. We need to know the risk factors for SAM and be vigilant about them at the time of the repair, which we said was a small ventricle, hyperdynamic left ventricle, septum greater than 15 millimeters, an anteriorly displaced closure line, excess posterior leaflet, and a narrow aortomitral angle. And using a systematic management protocol, intraoperative and postoperative SAM can be effectively managed and treated with good outcomes. Thank you.
Thank you. Questions from the floor? Again.
Well, I understand, according to your quite extensive investigation, you could not predict SAM. Is it correct?
No, we did predict SAM. Those were the 5 predictors for SAM. If you could put my slides up. Right, the last slide there showed us the 5 predictors for SAM, preoperatively.
I'd like to come back to what I said before after the presentation of Professor Dion. I think the most important factor is when there is a size discrepancy between the anterior leaflet and the effective orifice that we have created. If the anterior leaflet is too large for the effective orifice, I think then the danger of SAM is high. And in my opinion, this is the most important predictor. That means during the operation, one has to make sure to size the residual annulus according to the size of the leaflet, like in Marfan's patients, for instance, or in degenerative valves. Of course, this risk is higher because the anterior leaflet is larger and a larger area may easier kink.
Yeah, no, I completely agree with you that the size of the anterior leaflet and an undersized annuloplasty ring increases the risk of SAM. What we're trying to do here is provide the surgeon with numbers that they can work with, as opposed to just saying, you got to make sure the anterior leaflet's not too long and your ring size is appropriate. We're trying to provide us with numbers preoperatively that you can use to help you predict that risk of SAM.
Yeah, thank you. I was curious, in your postoperative algorithm, how did you pick a gradient less than 50? Because a gradient of 40 in a steady state in an already hyperdynamic ventricle, and those people have any activity level at all, it's going to progress. Did you ever do any stress testing on these patients afterwards, or why did you come up with a mean of 50 or a gradient of 50 that seems high?
Yeah, we get asked that question quite a bit. The reason why we chose that is we wanted to have a little bit of reservation before we operate on the patient. And so when we looked at the patients we have reoperated on from other centers who've had SAM, but as I mentioned, between year 1 and year 11, most of them are symptomatic somewhere around a gradient of 50. And obviously depends on how much MR they have. Some people have a gradient, don't have as much MR. And so rather than being very liberal, we thought we'd be a little bit more conservative. And then symptoms are obviously the most important thing when a patient's already had surgery.
Robin,
Yeah.
just to clarify, when you have SAM and you go back, you said your favorite technique is to put a short cord in to pull the posterior leaflet down. Do you ever, you say you would never use a sliding plasty, or which patient would you choose that, or perhaps reducing the height of the posterior leaflet directly?
So in the patients that we have had SAM, some of them did receive a posterior leaflet sliding plasty. However, the reason why we would just go towards putting a single neocord is just for a time-saving factor. We've already true-sized the ring, and except for one recent case that occurred after that we published this paper where we did upsize the ring to 2 points, went from a 26 to a 30. But in most cases, shortening that posterior leaflet just adds, can be done with 1 dose of Plege, come off bypass, you displace that closure line posteriorly, lengthen that coaptation septal distance, and we've always had SAM resolve with that.
I'd like to make a comment about what you said. I don't understand why you would bring the sliding plasty into this matter. If you have a SAM due to a too high posterior leaflet, either you do as they say, which is to pull down further the posterior leaflet down into the ventricle, or if you want to redo the repair, is just reduce the height of the posterior leaflet and reattach it to the to the annulus. But then you have to do it for the whole posterior leaflet.
So you mean leaflet? You're saying leaflet reattachment.
Yeah.
That's what you mean, leaflet reattachment.
Leaflet
Shortening and
reattachment,
leaflet
yeah, but
reattachment.
which is not a sliding plasty.
Yeah.
I mean, and I really think that when you mention this issue, I don't have this incidence of SAM by far. I don't even have 1% SAM over hundreds of mitral repairs. So I don't understand at all what we're talking about. I think that if P2 is usually in all this degenerative disease very high as compared to P1 and P3. So if you pay attention to this closure line that Robert Dion has emphasized, which is to have a closure of 2/3, 1/3 parallel to the posterior rim of the ring. If you really reduce the height of P2, you really never have a SAM, never. It is just impossible. So whether you explain it as Professor Hetzer says, because there is a discrepancy between the ring of the anterior leaflet, or because you just say that you allow the posterior leaflet to push the anterior leaflet into the outflow tract, whatever the explanation, He's right, we are right, but anyhow, it's just because the posterior leaflet it allows the anterior leaflet to go into the outflow tract, and it's too high. That's all. I think. Okay, we should move to another talk.